First, just a quick reminder, as per usual, this is being recorded, so just let us know if you have any issues with that, and feel free to turn your camera off as well. And I'd probably suggest we all have our cameras off while Stan's giving his presentation, just to minimize any connection issues. I want to just make sure we acknowledge the traditional custodians of the lands on which we are all meeting today. For myself and my ANU colleagues, for most of us, that's Ngunnawal Ngambri country. But I also want to extend that respect to the to the traditional custodians of the lands on which anyone else is joining us, if those lands are different, and pay my respects to their elders past and present. And also extend that respect to any Aboriginal and Torres Strait Islander peoples joining us for this seminar today as well. The sovereignty of this land was never ceded, it always was and always will be Aboriginal land. We have a quick announcement. If I can get my slides working. So Alicia and Anne just wanted me to pass on that they have organised a fantastic initiative for our HDR students, an HDR writing group. This is going to be held fortnightly, and as of next week, that'll be fortnightly from 1 till 4 p.m. And students can sort of drop in and out as they choose. And it'll be in the Florey building, so a nice location for anyone kind of joining us for the lunchtime seminar at Innovations Theatre. Pop over to Florey for the writing group as well. There's a link there on the slide and an email address for Alicia and Anne if anyone has any questions, wants any more information. And please do encourage your PhD students to go along. Okay, so without further ado, I want to introduce our guest speaker today, Dr. Stan Steindl. He's going to be presenting to us on the effectiveness of compassion-focused therapy, 3 studies from the UQ Compassionate Mind Research Group. Stop sharing there, Stan, so you can go ahead and share your slides. So Stan is a clinical psychologist in private practice at Psychology Consultants Pty Ltd and an adjunct professor at the School of Psychology at the University of Queensland. He's a co-director of the UQ Compassionate Mind Research Group and convener of the annual UQ Compassion Symposium. His book, The Gifts of Compassion, How to Understand and Overcome Suffering, is a popular self-help or therapy companion book based on compassion-focused therapy, and I am sure we're going to find more out about that today. Thanks so much. Over to you, Stan.
Great. Thank you, Jo. Is it all sounding and looking pretty right? Excellent. Great. Well, it's lovely to be here with you all the way down there at ANU. Thank you, Jo, for inviting me along, and thank you, Lee, I think you're there as well, for recommending me, and to everyone, of course, at this new School of Medicine and Psychology at ANU. I too would like to just pay my respects to the traditional owners of the land and elders, both past, present and future, noting that we have some important decisions to make in the not too distant future, and so hopefully we can do that with compassion. I'm coming to you from Gubbi Gubbi country, which is actually at Mooloolaba on the Sunshine Coast. So you might look at me wearing a jumper and wonder what on earth am I doing, because I probably can't really complain about the cold up here, although anything, you know, sort of below 25 degrees is very cold in Brisbane, so we get out the woolies. But also welcome to all. We're all the same, not in every way, but in some very important ways, and so this is worth honouring and celebrating, and our differences are also good. So a difference in you is a gift for me. So knowing all of this, what else but equity, inclusion and compassion? Oh yes, this has sort of been mentioned. Just to also mentioned Dr. James Kirby, who is also co-director of the Compassionate Mind Research Group and one of my dear friends and collaborators in some of the stuff that I'll go on to share with you. And my publisher does say I must always mention the books. So thank you, Joe, for mentioning them as well. The Gifts of Compassion, as well as a personal practice workbook. And a lot of the stuff that I'll be talking about, at least from that clinical point of view in terms of CFT and how that might roll, can be found in these books and some others that I'll mention towards the end as well. Just keep an eye on the time. So I just thought hopefully it will go this way. The seminar might just talk a little bit about what is compassion-focused therapy. I wasn't exactly sure what you all might already know, and so apologies if some of this is very familiar to you already, but just thought I'd talk a little bit about what is CFT, some of the history maybe, and just some of the underlying principles there. And then sort of give you a bit of a snapshot really of 3 studies: CFT for body and weight related shame, CFT for veterans with PTSD and their spouses, and CFT for adult female survivors of childhood sexual abuse. We have, or I've sent Joe copies of these slides and also copies of those 3 papers. So if anyone does feel interested in this or wants to know more, or at least dive deeper into the papers to properly critique them and so on, then yeah, by all means, they should be available to you there. Any of the other papers that I refer to as well, just let me know. I'm happy to send PDFs if you're interested. So I just, wanted to kind of mention a little bit about what is CFT. It's kind of relatively new-ish. It's sort of more and more established now, really, but basically compassion-focused therapy is an approach to psychotherapy. It's rooted in evolutionary psychology in particular, but also attachment theory, psychological sciences, and an understanding of the evolved motivational systems. And this is probably a key bit of it that we might briefly refer to a little bit later as well, but also the wisdom and spiritual traditions. Professor Paul Gilbert developed it originally, and he was trying to work with people who are high in self-criticism and shame, these kind of ubiquitous transdiagnostic constructs that often we're working with in therapy. And there really is a growing evidence base. James, myself, and Cassie Telligen did a meta-analysis in 2017 exploring depression, anxiety, and stress, life satisfaction and happiness. There's a review paper there looking at CFT with eating disorders, PTSD and complex trauma from Lisa McLean and others, and another meta-analysis from Madeline Ferrari as well in 2019 and her team. And I'll talk a bit more about this in a sec, but as a psychotherapy, it really focuses on the therapeutic relationship, assessment and case formulation, goal setting, treatment planning. The Matosh and Steindl paper there, 2020, that's a case study that we wrote. One of my cases, we kind of wrote that up, and it just is a nice little way to have a sense, I guess, about how compassion-focused therapy might be used clinically. If you haven't already and you're sort of interested in this stuff, then Gilbert and Simosh 2022, Compassion-Focused Therapy, the book there, that's really the CFT Bible now. It's got lots of, the first half is Paul talking a lot about the approach and the theory and so on, and then the second half is a lot of particular applications and tricks of the trade and all of that sort of thing. So that's a great resource. Just to make the point that CFT incorporates compassionate mind training. It's sort of interesting because people often ask, what's the difference between CFT and CMT? And I'm probably moving a little bit towards, it's all just CFT. CMT is, I guess, the psychoeducation and skills-based aspects of CFT, but it can become a little bit confusing, I think, in some ways in the literature. So I think we're really moving towards CFT, brief CFT, group CFT, and that incorporates some of these training and psychoeducation aspects. But CMT, I guess, is the definition of compassion across 3 flows, including some of the common fears, blocks, and resistances to compassion, really focusing in on the evolved nature of the mind and body, that we have tricky brains and we get caught up in loops of the mind, old brain, new brain loops, and that the nature of our suffering, not least psychological suffering, is not our fault. And there's a range of skills, attention training, mindfulness, body-based practices, imagery-based practices, method acting, chair work, embodiment practices that we might bring to all of this, especially towards the cultivation of the compassionate self, the part of ourselves that is wise, strong, courageous, and is committed to being caring and helpful. And we bring the compassionate self to help us manage life's difficulties, not least our own self-criticism. And so as a psychotherapy, actually one of the interesting points is that it's really applicable as a companion to any therapy modality. So just by way of example, we might bring a compassion focus to cognitive behavioral therapy, or we might bring a compassion focus to acceptance and commitment therapy. But we might also do CFT as a kind of standalone therapy as well. But there's the importance of creating a therapeutic relationship. Client feels heard and understood and safe. We might carry out a thorough assessment of the person. They're presenting problems, their life experiences, but including psychometric assessment, not least of compassion and fears of compassion. We use an evolutionary functional analysis, trying to develop a shared understanding with the client about their evolved functions of the brain and how that's tricky and how that can be a part of the nature of suffering. And we develop a treatment plan, incorporating CMT, all of that psychoeducation and skills, but also individualized aspects to treatment and evaluating outcome and so on. And CFT is often presented in groups. In the literature, it sort of ranges really in number of sessions and lengths of sessions. It might be very minimal intervention. So there's some studies of quite brief compassionate mind training, 2 hours of a presentation and psychoeducation, followed by people going away with skills and practices to do in between sessions for a couple of weeks, self-directed, all the way through to 12 or 20 sessions, often 2.5 hours in length. Compassionate mind training itself is an 8-session course developed by Chris Irons and Charlie Heriot-Maitland. They've published that in 2020. 8 sessions, 2.5 hours per session. I run those CMT courses just privately, but also we're actually doing a study at the moment with university students, trying to see can CMT kind of help them get through the stresses and strains of university. Our research has tended to use a sort of a 12-session approach, weekly or twice weekly. I'll go on to explain all that in a moment. And actually, really, a lot of the research conducted so far is CFT in groups. So it's kind of a therapeutic approach designed to help people suffering, especially with high levels of self-criticism and shame. And it's applicable in the treatment of mood disorders, eating disorders, PTSD, childhood sexual abuse, personality disorders, psychosis, but also business, politics, sport. It's really becoming quite widely used. So just to give you a little bit of the history and I guess the underpinnings, it was developed by Professor Paul Gilbert. I thought this was a very handsome photo of Paul. So I was sort of wondering, is he looking back at the evolutionary flow of life, or is he looking forward to a new compassionate future? It could be a little bit of both. Anyway, he was working with, many years ago, he was working with people suffering from depression. In fact, his first book, or one of his early books, is Overcoming Depression, a self-help book, and it's been through many reprints and so on. And he was working with people using a CBT approach as an effective treatment of depression. He's sort of really originally a CBTer. But he kind of noticed that people sometimes could challenge their thoughts, but in a very critical tone. So they would say, you know, don't be ridiculous. Of course, people like you, or something like that. So it was challenging their, you know, sort of cognitive errors, but with this very critical tone. And of course, they didn't feel any better. And so he really began by trying to help people to create a warm, friendly, caring inner voice tone, caring, self-to-self relating. And it was from there that he really developed this notion of compassion and bringing compassion or self-compassion into that self-to-self relating. He defined compassion as a sensitivity to suffering in self and others, with a commitment to try to alleviate and prevent it. If you're interested, this 2020 Frontiers in Psychology paper, it's long and rich with all of his, you know, kind of ideas. And I mean, he really is a genius, Paul, you know, in terms of how he's integrated all of these different aspects. And so that paper is a really good summary of his approach to compassion and compassion as a psychotherapy. And the definition's interesting. It's a sensitivity, like it's noticing suffering in particular. Compassion is about suffering, but in the definition, it's self and others. So it really starts to give us that sense of the flows of compassion. And it's a motivation. Compassion is a motivation and a commitment to try to alleviate and prevent that suffering. And so he absolutely sees compassion itself as an evolved motivation. And of course, some of the underpinnings here are we're all born, you know, after thousands of years of human evolution and adaptation, and specifically the evolution of the human brain. We're born with specific genes, strengths and weaknesses that we get through no choice of our own, and then into a social context that we also don't get to choose, and life experiences just start to happen. It's all a bit of a lottery, really. And of course, in terms of the tricky brain, we have certain old brain functions, evolutionarily speaking, motives especially. So we're very interested in harm avoidance or threat protection motives, motives around food or sex, and motives around caring and connection. And then the emotions that drive, or the motives might drive various emotions, such as anger, anxiety, sadness, joy, and various behaviors that we might bring to that. Of course, fight, flight, freeze, courting behaviors, caring behaviors, and so on. I won't go very much into this, but really at the heart a little bit of CFT for Paul is this notion of social mentalities, these different motives: care-seeking, caregiving motives, cooperation, competing, sexual motives, and so on. And the way that we view ourselves and others from the perspective of these motives, but they come along with certain fears as well. This is detailed in that compassion-focused therapy book I mentioned right at the start. So that's kind of old brain motives, but then we have sort of new brain functions: self-monitoring, self-awareness, imagination, envisioning, remembering. But that all comes along with difficult challenges too. With the self-monitoring becomes self-criticism. Imagination becomes fearful imagining. We develop fear of feelings, emotional avoidance. We have the ability to feel self-consciousness and shame. And remembering becomes rumination. So we can get caught up in some very difficult loops of the mind in terms of these old brain motives and functions and these new brain functions, and how that can really become a source of suffering. And probably a central tenet, if that's the right word, of CFT is, you know, all of this, it's not my fault, but it is my responsibility. So CFT brings in that evolutionary aspect to help people to sort of steer away from blame and shame, really trying to de-shame in terms of just how the brain works and that it's tricky and that it can be a source of our suffering. But without resignation, without disempowerment, without careless disregard, but taking responsibility to kind of manage all of that. You know, the brain is an organ, has various outputs, desires, motives, and so on. And what arises is not my fault. It's produced from my genes, my social conditioning. But I need to learn how to deal with this stuff psychologically, hygienically, if you like, taking responsibility to learn about the mind, cultivate a compassionate intention, and take steps to prevent and alleviate suffering. I have to take responsibility for my mind or what it does without blaming, criticizing, shaming myself for what my mind does. So really, we're trying to draw on the evolved old brain caring motive, perhaps that we share with other mammals and so on, bring in the new brain, social intelligence, awareness, intentionality, those new brain competencies. And that helps us to then start to cultivate compassion and self-compassion. So that, I suppose, is some of the underpinnings. We think about three flows of compassion. Compassion for others, which is obviously the most fundamental focus, I guess, of compassion. This motivation to be helpful, noticing others' suffering, tolerating our own feelings of distress, being non-judgmental, being empathic, and then being prepared to do something wisely to try to alleviate and present that suffering. We sort of think of it as compassionate engagement, the sensitivity, and compassionate action, the doing something to alleviate and prevent the suffering. But the second flow of compassion is receiving compassion from others, which is both an openness to receiving compassion from people around us, but also whether we feel they're there, they're available, they're supportive or skillful, that they're offering us the kind of compassion that we need. So it's tricky. Receiving compassion can be tricky. And there's a lot of evidence, you know, about the availability of compassionate social support being helpful in terms of resilience and psychological outcomes. For example, openness and access to compassionate relationships help to buffer the negative life events on depression and help with our psychological well-being. Then, of course, self-compassion, compassion from self to self. If your compassion does not include yourself, it is incomplete, says Jack Cornfield. So it's a kind of an alternative to self-criticism, negative self-evaluation. Instead, it really asks, you know, what do I really need right now? What would be helpful for me? What could I do that would be in the service of my own health and well-being? And we know that self-criticism are associated with vulnerabilities to mental health problems, particularly depression. And low self-compassion is related to paranoia, shame, self-criticism, various psychological or psychiatric diagnoses. And the last key bit too is that we have the three flows of compassion, but sometimes, odd as it sounds, we have fears, blocks, and resistances to those three flows. We have fears, which is a kind of a fear response, an avoidance to the idea of compassion across all three flows. Compassion will make me weak and vulnerable. People will take advantage of me. Being compassionate towards myself will expose me too much to painful feelings and just make me feel worse. We have certain blocks, which is where we'd like to be compassionate, but something gets in the way. Often maybe a lack of time or a lack of resources, or not really knowing or understanding suffering and what to do to help. That can all block compassion. I don't know how to be compassionate. I never know what to say. I really don't deserve compassion. I should be compassionate towards others, but being compassionate towards myself is too self-indulgent. And then we can also have resistances to compassion, where perhaps the person could be compassionate, but isn't. not because of fear, maybe, although maybe that's beneath the surface somewhere, but rather maybe they see there's no point to compassion, or they're too focused on other motives, competitive motives, for example. Compassion is stupid and foolish. It's dog eat dog out there. You need to be tough. I'm not one of those silly do-gooders. I don't want to sit around with a bunch of hippie types crying and bitching. Feels too much like self-pity. So we have these fears, blocks, and resistances to compassion. And in some ways, working with the fears, blocks, and resistances is the work of compassion-focused therapy. This is just a little qualitative paper that James and I did with Tobin Bell and Alison Dixon, asking therapists to talk about how they might work with fears, blocks, and resistances. And they sort of said, we've got to be prepared to work with FBRs in CFT. They're going to come up along the way. And we need to kind of help the person formulate the FBRs, to understand where they're coming from, to de-shame them, and to address FBRs directly through experiential interventions or cultivating safeness and connection in the therapeutic relationship. So that's that little paper there. I quite like that one. It gives some nice practical suggestions about how we might work with fears, blocks, and resistances. And I won't spend much time on this, but as you can kind of maybe sense, people feel ambivalent sometimes about it. They feel two ways about it. They'll have these reasons or motivations to be compassionate towards others or themselves, but then they'll have these fears, blocks, and resistances, which kind of get in the way or cause them to hesitate or have reservations. So often motivational interviewing is a nice adjunct to CFT to help people work through that kind of ambivalence. And so in terms of treatment plans, we might have these phases: establishing the therapeutic relationship, doing the assessment and intake and so on, but creating a case formulation, doing some of that de-shaming. And then we move into psychoeducation about the model, the evolutionary model, the tricky brain, the old brain, new brain loops, compassion across the three flows, working with the fears, blocks, and resistances. Then we start some compassionate mind training and skills development, body-based practices, imagery-based practices, creating a sense of the compassionate self. And then we put the compassionate self to work, working with perfectionism, self-criticism, shame, and so on. So that's a little bit of a snapshot on CFT itself and how that kind of all works. It's an evolved theory, and we eventually cultivate that compassion as a superpower. I just to say that I sort of put a lot of effort into that particular slide. So let's just sort of pause there and look at my amazing art and so on. All right, that'll do. So there's a lot of work going on and so on, but I thought I'd just mention to you now 3 clinical studies that we've done here at UQ in the Compassionate Mind Research Group. Just to give you a feel for some of the work that's happening and not least around the effectiveness of compassion-focused therapy. The first one is compassion-focused therapy to reduce body weight shame for individuals with obesity. This was actually a randomized controlled trial. This is Alicia Carter's PhD, now Dr. Alicia Carter, and James Kirby was her supervisor. I was lucky enough to be involved as the, the group facilitator, I suppose. I was helping with running the sessions. It was an RCT with 2 conditions. We had the group CFT versus a waitlist condition. Participants needed to be 18 years or older, have a BMI of 30 or more, and have high levels of body weight shame. There were, in the CFT group, there were 28 participants, two were males. In the waitlist, it was 27 participants and 2 were males. And the age ranged from 19 to 70, with a mean age of 46 years. And this was an intervention which was 12 2-hour sessions of group CFT. participants, were considered complete as if they attended 10 out of the 12 sessions. But we used a 12-session manual that was developed by Paul Gilbert, and the sessions really were an introduction, compassion, the tricky brain, 3 types of emotions, threat-based emotions, drive-based emotions, soothing, affiliative emotions. There was attention training, mindfulness and soothing rhythm breathing, safety, safeness and compassion from others, developing the compassionate self, bringing the compassionate self to multiple selves, angry self, anxious self, sad self, and then working with self-criticism, shame and guilt, deepening the compassionate self, and then bringing that to compassionate assertiveness, forgiveness, trying to create healthy relationships, and then finally envisioning a compassionate future. Just a little exciting kind of point. James Kirby, Nico Petrocchi, and Beatrice Spaldi have completed, I think, the manuscript for a CFT manual, which has been long waited, and it's now in press, and I think it might be coming out next year. So that's very exciting for all of us CFT groupies. We had a number of measures, pre, post, and 3 months and 6 months follow-up. Just to highlight a couple of things: body weight shame scale, Duarte and colleagues, the other is shamer scale by Steve Allen and Ken Goss. And we also measured heart rate variability as well as a number of other things there. But the some of the results pre-post, the CFT group significantly improved in terms of their body weight shame from externalized. So this is that sense that others are criticizing, judging, disapproving, shaming of us and our body and our weight. And so there was significant improvement from pre to post. We followed the CFT participants up 3 and 6 months. And there was a little increase there, in a significant increase in this externalized body weight shame. I don't know whether this is what it is, but one of the things that participants reported during the group was that they would be actively shamed. People would say stuff. Now, sometimes that was, I guess, well-meaning people, doctors or other clinicians, and commenting and so on. Sometimes it would just be the guy on the building site or someone at the shops, and or family members as well. So I thought that was a possible thing to kind of go on and look at, that they worked hard in their CFT group, but then they went out into the world and people continued to sort of make these comments and so on. And so, externalized body weight shame kind of bounced a little bit. The internalized body weight shame, that's that sense of us judging ourselves, criticizing ourselves, disapproving of ourselves, shaming ourselves. That also significantly improved pre to post. And actually, there wasn't any further change from post to follow-up. So those effects kind of were maintained a little bit more so, 3 to 6 months. The other is shamer scale, which really measures external shame generally, that sense that others see us as inadequate, inferior, no good, and so on. That significantly improved from pre to post and was also maintained from post to follow-up as well. A few other highlights from this particular study. We used the self-compassion scale by Neff, and we saw significant increases in self-compassion across the self-kindness, common humanity, and mindfulness subscales. And we saw significant decreases on the self-compassion scale on the self-judgment, isolation, and over-identification subscales. We also saw significant decreases in fears of compassion. So people were less fearful of self-compassion, compassion towards others, and receiving compassion from others. And finally, there were some non-significant results, which was curious as well. Depression and anxiety and stress didn't change. I forgot to mention in the slide earlier, so we also measured heart rate variability. And unfortunately, that didn't change across this intervention. It's actually a common one that's used quite often now in compassion-based research as a kind of a measure of parasympathetic nervous system activation. Maybe it was the sample size, maybe it was practice effects. You know, we didn't measure how often people did the practices between sessions. Maybe it's the dosage isn't enough or something like that, or other factors not yet measured. But that was kind of a disappointing finding, but there it is. The heart rate variability didn't so much change. So the second study I thought I'd give you a little snapshot of as well is compassionate mind training for ex-service personnel with PTSD and their partners. So this was run by Maddie Romanuk and her team at Gallipoli Medical Research Foundation and at Greenslopes Hospital, and with us at UQ. Once again, I was happily involved as the facilitator of the groups and so on. I mean, it's a little bit anxiety provoking because you wait with bated breath to see, you know, what happens when we follow everyone up. But this was sort of more thought of as a pilot study. So unfortunately, it wasn't an RCT, but we wanted to sort of see, like, how might veterans receive this stuff? Sometimes people worry that male veterans, you know, kind of, this was an average of 59-year-old, you know, male veterans. Maybe they wouldn't warm to compassion. They'd see it, they don't like the word maybe, or they worry. And actually a lot of them worried that self-compassion might be too much like self-pity, like I said before. But so it was a bit of a pilot study. But the really cool thing here, I think, was that the participants were veterans and their spouses. And so anyway, this was the same intervention, the same manual, Paul Gilbert manual that I described earlier. But this time we delivered it twice a week for 6 weeks, because it's a lot of time, you know, 12 weeks, 2 hours a week. We were trying to see if we did it twice a week, would that also be easier to attend? The fun bit here was we included dyadic exercises. So the veterans and their spouses would do some of the exercises, for example, imagery exercises or other sort of interactional exercises together as couples. A couple of particular measures of note. Well, we did pre, post, and 3 months here. We used a PTSD checklist, the PCL. There's the other as shame scale, again, the external shame. And we also had a relationship assessment scale as well as a number of others, fears of compassion, self-criticism, social safeness, and so on. We looked at PTSD symptoms separating the veterans and the spouses. The spouses weren't diagnosed with PTSD, and as you can see there, as a group, had lower PTSD symptoms on the PCL. But the veterans improved across from pre to follow-up. They had significant reductions in their PTSD symptoms. We combined veterans and spouses for some of the other analyses. And here we have external shame. This is the one measured by the other as shame scale. And yeah, as you can see, the group significantly reduced in external shame, that sense of others seeing them as inadequate, inferior, no good, unlovable, shameful. So this is interesting. We're starting to get some kind of repeated findings here. The first study, external shame significantly reduced. In this study, external shame significantly reduced, but so too did the post-traumatic stress symptoms as well. And the really exciting bit here is relationship satisfaction significantly increased across the combined veterans and their spouses, and kind of maintained over that 3-month follow-up as well. So I'd really like to follow this up, you know, bringing couples into CFT and kind of see how that might further help in the relationship wellbeing. Put those in twice, sorry about that. Some other highlights: there was significant increases in reassured self, that ability to kind of reassure oneself, sense of social safeness, quality of life and satisfaction increased, and the fears of compassion decreased. So fears of compassion towards self and other, or receiving compassion from others, all decreased. Self-criticism decreased, that sense of inadequate self, that sense of hated self. Anxiety and stress decreased. Depression was non-significant in this study as well. And so the third study was compassion-focused group therapy for adult female survivors of childhood sexual abuse. And we sort of thought of this also as a preliminary investigation. This was led by Lisa McLean, Dr. Lisa McLean, Matthew Bambling from the Department of Psychiatry at the School of Medicine at UQ was her supervisor, and I was secondary supervisor. In this one, I wasn't involved in the facilitation of the groups. This was beautifully done by Lisa. So it's a preliminary investigation, again, not a control group, unfortunately, but it's group CFT. Participants were adult female survivors of childhood sexual abuse. There were 25 women aged 18 to 65 with a mean of 41 years. And Lisa put a lot of effort into creating a sort of a trauma-informed CFT approach. She kind of called CFT-SA. And actually there's some qualitative work that she did and a pilot that she did, trying to really work out with the clients themselves, but also the counsellors that work with them. You know, what do we need to do to make this a trauma-informed approach? It was 12 sessions, 2 hours a week. And she developed a slightly different manual where she did an introduction and mindful attention, did a couple of sessions understanding compassion, then went into compassionate thinking and reasoning, compassionate feelings and emotion, a couple of sessions on shame and compassion, moving into compassionate behavior or action, exploring compassion and trauma for a couple of sessions, and then maintaining compassion for a couple of sessions. In this one, we use the compassion, engagement and action scales. And the nice thing about this particular scale, different to the self-compassion scale, is this one is really based on the CFT theoretical model. And so we just used the self-compassion subscale of that measure. But we also used the PCL and the other as shame scale, as well as the external and internal shame scale. I thought I'd just mention that because that's a sort of a newish scale that, well, has subscales of external shame and internal shame, as well as a global shame score as well. Only 8 items, and it seemed to work very well in this study. And we found increases maintained for self-compassion, decreases in external shame, and also global shame from the beginning to the end, and decreases in PTSD symptoms as well. And so there's this really fascinating, these findings starting to appear, which is that without actually targeting PTSD with a sort of a trauma-informed approach, such as prolonged exposure or those sorts of things, by really just working with compassion and cultivating compassion and self-compassion, people were able to have really kind of significant changes in their PTSD symptoms. And there's in the paper you'll find some clinical significance data as well in terms of the changes that people experience there. So that was quite exciting. It can be helpful with the shame and with the trauma-related symptoms. And just some other highlights again, reassured self, quality of life and satisfaction increased. we seem to be able to reduce fears of compassion. In this study, we only used the fears of compassion regarding self-compassion and regarding receiving compassion from others. But both of those decreased. Self-criticism, inadequate self and hated self decreased, and depression, anxiety, and stress decreased. So, just some tentative conclusions, I guess. We're just at the early stages still in some ways, but CFT in groups seems to be helpful for various people in various life situations. People struggling with body and weight related shame, veterans with PTSD and their spouses, women recovering from the traumatic effects of childhood sexual abuse. As I said, notably, CFT may be helpful in reducing shame, which is kind of, originally that was the self-criticism and shame were really the primary targets, but also reducing PTSD symptoms without necessarily targeting PTSD through the trauma-focused approaches. And there are also helpful effects across a range of constructs. Obviously, compassion increases, fears of compassion decrease, self-criticism decreases, social safeness, quality of life, and relationship satisfaction increases, among other things. There are several limitations. I mean, these are sort of modest studies in a way, small sample sizes, not a very long follow-up, but some follow-up there, some longitudinal data. There are several outcome measures in each of the studies, given the small sample sizes, and culturally quite narrow, largely a sort of white Australian sample. And, well, for two of the studies, a lack of control groups. I mean, RCTs are difficult to do. So, kudos to Alicia there in terms of, I know that she put an enormous amount of effort into creating this as an RTC with RCT with some really good follow-up. And clinical samples are difficult to do. So kudos to Maddie and Lisa as well for really creating a wonderful clinical study. And just to quote James Kirby in his book, Choose Compassion, there is no perfect compassion, just our genuine attempts to be helpful. And I feel like, there's something in that too. We sort of definitely made a bit of a genuine attempt. So nearly finished. I thought I'd show you just a couple of things about the Compassionate Mind Research Group before we do finish. But yeah, I just thought I'd also see if there are any comments there or any questions at that point.
Feel free to jump in, anyone. If anyone has any questions, or raise your hand. Liz, do you want to unmute yourself?
Great. Thanks, Jo. Stan, can you hear me okay?
Yes, can hear you.
Stan, very much appreciated your presentation and your broader body of work. I also work in eating disorders, and this may be slightly out of your area of expertise, so just let me know if you don't have particular thoughts on this. But yeah, I notice in the literature on CFT, as is the broader literature on people with anorexia nervosa and lower weight eating disorders, that it's harder to get shift in the strength of the inner critical self. And I'm wondering if you have any thoughts about that. I mean, in what I've read, it looks like there's suggestions to increase the length of CFT, which is standard, that we need longer treatments for anorexia nervosa. Or would you have suggestions about changing the type of therapeutic approach that we adopt there? That are there ways that CFT should be modified when working with people with lower weight eating disorders?
I haven't conducted any sort of effectiveness work with that. I'm actually currently working with an eating recovery program in the States who are implementing CFT in their treatment program, their sort of inpatient treatment program. And there's two thoughts that come to mind for what they're worth. But the first is, I really think that one of the keys here is trying to work with what might be the fears, blocks, and resistances. I think that's often what can be a little bit missing there is that there are some very powerful fears at play in terms of what it would mean to be less self-critical. And the fears are that self-criticism, motivates me and helps me to achieve and so on. And self-compassion would make me self-indulgent, lazy, and also get further and further away from my sense of my ideal self. And so we've been working hard with that group to sort of see how can we sort of try to work with those fears. The other piece is, I do think that we want to try to, what's the word, kind of tailor it to the eating disorder population, trying to have relevant examples or anecdotes. And also quite often there's an age aspect to it as well, and sort of trying to communicate some of these concepts. At least at this particular place that I'm working with, it's often with younger people, 18 to 24, say, and trying to sort of translate some of these ideas in a way that they really can take on board. That there was this sense that self-compassion is cringy, was the idea that some of the clients have reported. And so trying to both adapt it for that more eating disorder population, but also keeping in mind the age group and other kind of factors like that. So that's a couple of thoughts.
Right. Thanks so much, Stan.
Any other questions, Stan? Nicole's got a question.
Yeah. Hi, Stan. Can you hear me okay?
Gotcha. Yep.
Yeah. Okay, fabulous. That was really, really interesting seminar presentation. Thank you for that. I'm really interested in how you collected your heart rate variability data. Obviously, you've had null findings for that. And I just wondered if you could maybe give us a bit more detail into what you did there, and if you think there are other factors that also might be contributing, given that the parasympathetic nervous system is influenced by a lot of daily stressors overall. And so, yeah, just wanted a little bit more detail on that.
Yeah. I am not the best person to ask about the detail around HRV. James Kirby is definitely doing lots of research in that area. But my understanding was that they were doing just sort of at-rest HRV assessments using, I can't remember the name of the equipment either, I'm sorry, but Alicia spent a lot of time bringing everybody in prior to the group starting and kind of collecting that data, and also after post-intervention as well. It's difficult to, kind of often HRV does shift with CFT and with compassion-based practices. So I think that's still a bit unknown or uncertain as to what might explain the null findings there. And so, yeah, unfortunately, I can't really enlighten us much more on that particular piece.
Thank you. I think I'll definitely read the papers to look at the methodology. I know I've been talking with Tegan and Mark from the School of Medicine and Psychology about some of these variables in some of their work that they're doing. So we'll look into that a little bit more detail. Yeah,
great. And let me know. I can also get on to James to get a sense of some details as well, or absolutely contacting him too, because he really is very interested in the psychophysiology of it all.
Sure. Thanks so much.
Just kind of building on that, I was wondering if maybe what could be going on there is because of that particular population, they're subjected to such pervasive stigma and an exclusion in society on a daily basis, that perhaps because of that context in which they're living in, that maybe it just wasn't enough to create those changes if they are influenced by stresses, which is my very basic limited understanding. But I wonder if that's part of it.
Yeah, that's really, I mean, just, and I'm thinking out loud myself too, but, you know, I wonder whether the body weight shame sort of, or the externalized body weight shame, the fact that that did increase over time might have played a role in the HRV findings, because obviously that would be threat system activating and sympathetic nervous system activating to be out and about and you know, still having to either deal with that or anticipate having to deal with it. So yeah, that's a really interesting possible connection.
Maybe one more question. Probably time for one more or two quick ones. One.
And just while we wait, just I put in a number of sort of the workbooks there that are available. CFT Made Simple is a nice way in if anyone's interested in learning CFT, and Experiencing Compassion Focused Therapy from the Inside Out is a self-practice, self-reflection book. James Kirby has published his Choose Compassion, so by all means get a copy of that. That actually, there's a lot of he summarizes some of the psychophysiology stuff in there. The Compassionate Mind Foundation, James and I have a podcast. I interviewed him recently at a bookshop, so that's up there as a more recent one. I have a YouTube channel. I always like to let people know about that. And by all means, be in touch anytime. Either just email me or through the various social medias. That would be really great. But yeah, thank you once again, everyone, for coming along, and I hope that's been helpful.
Yeah, that's been great. Thank you so much, Stan. Fantastic presentation. And we got some applauses.
Okay.
Oh, fantastic. I mean, I have so many more questions, but we are out of time, so maybe I'll have to wait for another time. But I have popped in the chat my email address if anyone wants any of those papers or the slides. Stan has very nicely shared them with us, so I'm happy to forward those on. Just shoot me an email. And yeah, I think that brings us to the close, the end of the seminar. So another round of applause for Stan.
Thank you.
And yeah, thank you so much, Stan. It's really great to have you. And we'll be back with hybrid sessions next week, our sort of lunchtime seminar. So looking forward to seeing everyone there. And for those on campus, please do join us for some drinks at Badger now, if you can. All right, thanks, Stan.
See you
Thanks so
later.
much. Thanks,
Bye.
everyone.